Welcome to the Physician Associate Podcast.
Hello and welcome to this episode of the Physician Associate Podcast. My name is James. Today I'm joined by Dr Sina Ghadiri. Welcome to the show, Sina.
Hi, James.
Thanks so much for joining me. I was really interested in a publication you put out recently in the Future Healthcare Journal, which is all about physician associates and how we can help train doctors in the 21st century. Can I ask where your interest in physician associates, where you first came across us, and where this publication sort of came about to start?
Yeah, sure, absolutely. So when I first came across physician associates was probably when I started foundation training. So throughout medical school, I was kind of blissfully unaware in a way. No one had really told me or kind of informed me exactly what a physician associate was. And I set foot on the wards as an F1, and then it suddenly dawned on me that there was this job out there, people called physician associates who were very helpful on the wards. And that was my first kind of interface with physician associates at that point in time. And then gradually, as I did my foundation jobs, then went into core medical training, I got to know more and more physician associates, came to know about how they worked and what kinds of things they could do, and in the different specialties, what unique skills that they could bring. So, for example, in gastroenterology, we had a physician associate who helped with acidic taps and acidic drains. And what drove me to do my publication was essentially, there was a call out by the RCP for what was called the Teal Essay Prize, which essentially they gave the title, Physician Associates, Friend or Foe. I applied to write the essay, and I spent a good amount of time researching and learning up and swatting up on everything that I could think about, and everything which was necessary to know about physician associates. And then it very naturally, organically, I think I started writing it. And it wasn't a very long piece. I think eventually it ended up being around, about 1,500 words, and I cut it down to about 1,000. So in the end, I just wanted it to be quite a succinct piece about how physician associates have integrated so far within the United Kingdom, and putting out some of the, I suppose, pressure points and some of the contemporary issues which physicians and physician associates face when dealing with each other, I suppose, in that sense.
Interesting title, Friend or Foe. Certainly there have, if you look online, and I try not to, there's certainly been a few comments that make me a little bit upset when you read some of the negative stories. I think things have changed a lot over 4 or 5 years as people have met more PAs and we've worked closer together. I think the attitude and culture is changing. I personally come down on the side of friends, obviously. I want to be politically correct here, of course, but from a kind of humanitarian perspective, or just kind of thinking for the best of humanity, the NHS is in a point of difficulty at the moment. It's never been under this kind of pressure. And if we start thinking of healthcare professionals who work closely with us as foes, then that is just not a very productive way to engage with an allied healthcare professional. And I think we need to work with each other as friends. So, of course, there would be some points of discussion and some, conversations to be had about how physician associates work with doctors. But fundamentally, I think it should be based on the principles of mutual friendship, and there shouldn't be any culture of malign intent, for example, or undermining. That kind of stuff should not really exist. I feel that that's kind of my personal opinion on the matter, really. And I've tried to emphasize that in my writing as well, and hopefully give a more balanced viewpoint and just kind of give both sides of the arguments, if there is an argument in that respect. Absolutely. I'm with you. Collaboration at the end of the day rather than competition. Obviously, it can be difficult for doctors and PAs who might be in training on the same departments and the same specialties, might be competing for the same opportunities. I guess that's one of the pinch points that you were alluding to.
It does hinge on the quality of the mentor who you have. If it's ward-based education that you're talking about, learning skills on the job, it really does depend on who your mentor is, who the consultant figure there is, for example, or it could be a senior physician associate. So someone who engages in teaching in a positive, productive manner, and also gives you the opportunity to have as many teaching opportunities
or learning opportunities as necessary in order to further the career which you want to have at the end of the day. And a lot of the time, especially as a junior doctor, I felt that the service demands quite a fair bit, and learning opportunities can get placed under pressure a little bit. Not so much in that there's competition between physician associates or doctors, but more that the demands of the job as a junior doctor is that you're kind of flung in several different places. You're covering a night shift here, then you're going back onto days, and then you've got a weekend shift, and then that all kind of adds up. And then you find out that over 2 months you've had maybe 1 or 2 solid learning opportunities during that time. And if you had a bit more time, a bit more protected time available, you could have engaged in kind of things which may be more useful to your career. So I think those are kind of 2 key points on the fundamentals of good learning, good teaching opportunities in a practical sense on the wards.
I guess one of the main factors is balancing the opportunities that you want to learn and progress in your career versus the service provision that we all provide in the NHS. And when there are rota gaps on top of that, it makes everything very difficult, doesn't it, for anybody to learn and progress?
Yeah, no, absolutely. I mean, the issue of rota gaps is something very pertinent. And on the subject of rota gaps, I mean, that's an area where there is some kind of conversation behind the scenes between the BMA and physician associate bodies with regards to what effective role can physician associates play in the various kind of slots in the rota. Would they be senior decision makers? Would they be kind of more junior decision makers? How would it fit in, and what kind of qualifications would they need to have to be able to make those decisions? And I don't think we've got a firm enough structure there to understand like how they would fit in yet.
I guess one of the big unique selling points between a physician associate and a doctor is the fact that we don't rotate. So we stay as permanent members in the department. So I guess that's a big plus in terms of how we can help efficiency and productivity on the department and help with training for our doctor colleagues as well.
Yeah, absolutely. That's a real boon to patient care and kind of how the general ward operates. Someone who would be there kind of Monday to Friday, who knows the patients on a daily basis, is a real positive, because a lot of the times these junior doctors are rotating from working in their specialty on the ward, doing, say, an acute shift for a few days, and then going on to nights where sometimes they may not be on their usual ward job for like 1 to 2 weeks. Whereas if there was a physician associate on that ward, they'd be there Monday to Friday in that specialty. They would know the patients inside out, and it would facilitate, things such as discharge, be more effective, more just a greater understanding of what's happening with the patient, and kind of liaising with other people who would facilitate, discharge at the right place and time. So there's definitely a thing to be said about having that constant presence within one specialty, which doctors, unfortunately, in a lot of specialties don't routinely get.
In your publication, one of the points that sort of stuck in my mind when I read it was around, obviously, at the moment, physician associates are an unregulated profession. Mm-hmm. We know that's going to change in the very near future. The General Medical Council are going to take over regulating physician associates, so they'll be setting the standards for PA education and, I guess, revalidation and fitness to practice and all the kind of stuff that they do at the moment for doctors.
Yeah.
There was a bit around, I guess, another potential pinch point of the cost of regulating PAs and how that shouldn't be a burden on existing physicians.
From my perspective, I would say that I suppose most doctors would, if they found their GMC fees going up by £50 to £100 at the end of the year, and if there was a kind of economic burden on us, I could imagine a few doctors being a bit unhappy about that naturally. The question is whether the GMC can work out something where the cost burden would not fall on doctors, whether there could be some other source of the money, because they may get some kickback if doctors, if they inform doctors that this is what's happening.
Yeah, okay. It's really difficult to know which way the profession's going to evolve in that space and what the GMC will allow as well.
That's true. And I think you're going to need to depend on strong leaders within the physician associate field, really. I know Kate Stroughton, the faculty president, she's doing a great job at the moment, and she's doing a lot of work to try and get prescribing rights through for physician associates. And I think we need, strong vocal leaders within the physician associate field in order to try to make sure that things progress in a fair way, and in an open way, and that other allied healthcare professionals are aware of what you guys do and the exams and hurdles that you need to pass as well, because there's nothing worse than being kind of ignorant of what other healthcare professionals have to go through and not understanding. And sometimes as doctors we are guilty of focusing too much in our own field and not understanding the trials and tribulations of other healthcare professionals as well. So yeah, it's a developing thing, really, isn't it? I suppose at the end of the day, and we all want to make sure that it progresses in the right way, and that the GMC come to a kind of fair understanding of how it's going to work, really.
Absolutely. I think it will evolve in different ways, probably in different parts of the country, until the GMC perhaps get a national standard and framework in place.
Interestingly, though, in America, I was chatting to a couple of physician assistants over there. There are quite a few of them who do specialize, and then they end up just working in that specialty for the rest of their careers. There are quite a few more dermatology PAs in America compared to the number here in the UK. And I wonder if their structure makes it easier in terms of doing qualifications after they graduate to allow them to specialize more effectively and to stay in that specialty without being, without moving from that perspective. I don't know if that's an observation that you find here, that a lot of physician associates are still quite generalized, and you don't see many kind of specialty focused physician associates.
Yeah, certainly if you look at the faculty's census every year, large, almost a third probably are in general practice, and another quarter are in acute medicine and emergency urgent care. So they're quite general. And then you probably have maybe just less than half of PAs that are into cardiothoracics or cardiology or peds or something more specific. There was a part of your publication when you were hinting around discussions that the BMA have had and votes that they've made about how they see physician associates. Now we're getting into some of the more thorny political issues, but wondered what you might want to say about that.
Yeah, that's the whole issue of whether doctors are happy for physician associates to fulfill similar roles as them, the same capacity in a rota structure, for example. And some doctors are quite adamant that physician associates aren't trained to the level that doctors would be to fulfill, for example, an SHO role in a hospital, for example, on an acute shift or something along those lines. And then that's when the kind of thorny issues come to pass, and you get some kickback and discussions, and things can get heated. I wasn't there at that conference, that meeting, but so I was just reporting on the after effects and the documentation which came out from it. But my personal viewpoint on this is that we need to be more accepting that a physician associate who's qualified to practice to certain standards, and if that's recognized, then they should be able to support us on certain rota points, or working, for example, potentially in the future in a role quite similar to an SHO. I mean, advanced nurse practitioners do that in quite a few hospitals, where they will work in quite intensive roles at night times and weekends, and support medical staff, and even sometimes helping with the learning of F1s and F2s on the job effectively. So I don't think we're in a position, really, kind of given how how much the NHS is in a position where it needs to consider how it needs to retain healthcare professionals, retain doctors, that we need to make sure that that wards can be run smoothly and effectively. And if there is a way for physician associates to help us to facilitate patient care, we need to be open to that, basically, I think.
I know back in 2019, the BMA took a sort of vote on this in their forum, and the junior doctors sort of actively opposed any medical associate professions being treated equally to them when it comes to the medical staffing rotas. And also passed another motion about postgraduate medical examinations being barred to anybody other than doctors. I get a sense, and it's only anecdotal, that there are more people who are changing their minds and coming around to the idea, especially perhaps
absolutely
post-pandemic recovery.
Yeah, that's kind of how I ended off my my publication. I kind of preluded that in a way. I do think people will change their minds on that, and you just need to see the rates at which F2 doctors are going into specialty training. It's just dropping off year after year. There are fewer of us kind of specializing and going into the route to become a consultant. And we can't keep this same rigid stance that we don't accept that other professionals would be working alongside us in that same manner anymore. I don't think, or you can't complain about staffing issues, but at the same time say that you don't want physician associates to even be considered to be working in a similar role. Do you see where I'm coming from with that one? So that's why I think that people will change their minds, and it's a matter of time. But I think we will get there eventually, and we will have more constructive conversations in this regard, hopefully.
I think you're right, absolutely. And it comes back to what we said earlier about we're here to collaborate, we're here for patient care together, and not to compete. I think there's a beautiful line in your publication that I just wanted to highlight, and it says, there appears to be a distinct line where physicians will oppose the growing autonomy of physician associates, and establishing this boundary of practice will be a subject of significant debate in the years to come. I think that is very true. We'll see what happens. Watch that space.
Yeah, absolutely. Yeah. It's hard because we're kind of prophesizing what's going to happen from this point, and the pandemic's completely thrown things, a different light on things, absolutely. And whether doctors will come out of the pandemic with a different focus and a more collaborative focus, then I think that would be a positive thing.
Certainly. And I think it's important for physician associates as well to remember that we are not doctors, and we are not trying to be doctors. We should be proud of being PAs and being something independent and different to that. And our training doesn't necessarily have to be the exact same exam or the exact same pathway. We have nuances in our professional capabilities and the way we're trained, and certain things about us that make us different and unique. And that's diversity is
Absolutely.
a strength.
And I think on that point, a bit more specifically, I suppose, in that being proud of the way that physician associates do provide a unique viewpoint and role in what they provide in the healthcare spheres, it's really important to educate the public. And I think that's something which hasn't been done well enough, be that in the form of campaigns or kind of advertisements in a way for the public to more understand what a physician associate is, some aspects of their job roles. Because a lot of the time, if you mention physician associates to a few patients who come in through clinic every now and then, it's very few of them would really have a kind of good grasp on what a physician associate is. Even between doctors, sometimes there is a bit of ignorance on that regard. And I think the public need to be better informed that, that in the future they may see a physician associate, and that's perfectly okay, and they're perfectly competent to do a job role that they've worked hard for, and they've undergone the relevant courses and exams. It's kind of getting across to patients.
I introduce myself as, hi, I'm James, I'm a physician associate. I can say it several times and I still get called doctor at the end. Thank you, doctor. So,
oh God, yeah.
It just doesn't mean anything to the average person on the street. And it's difficult. And like you say, there's even amongst doctors and nurses and midwives at the moment, there's a lot of misunderstanding and apprehension about the role. So there certainly is a lot of PR and hearts and minds that we need to win over.
And that's why things need to change. And it shouldn't fall on PAs specifically to be out there trying to prove themselves. Because let's face it, PAs have done, an undergraduate degree, they've gone and done 2 years of further training. These, a lot of times, are very qualified people doing their job role. And then to have to go out there and prove that kind of who they are, and tell the public who they are on a kind of repetitive basis, I can imagine that would be quite arduous. And we need. That's why I say that we should get to a position where the public are better educated about what a physician associate is, and whether that's a government campaign, something. I think it needs to be something which is centrally driven. To be like to highlight physician associates to the public.
It's in terms of numbers as well. Like, where are we? We might have something like 3,000 or 4,000 PAs at best guess. Maybe not even that many quite yet. That's including students that are at university courses.
Yeah,
and we churn out close to 7,000 or 8,000 medical students a year. So there's nowhere near that we're going to be on the same scale of doing that. So it's growing.
However, you are growing quite well and healthily. I think over the past 3 or 4 years, the number of physician associate graduates has almost quadrupled, if I'm correct.
Oh yeah, absolutely. Yeah.
So it is growing healthily. And I think eventually we get to the point where you will become better recognised. And it's frustrating that it will take a little bit of time to get there. But I hope it becomes a point where it reaches a number at which people kind of have to take notice, and the public realizes what a physician associate is in the same way that they go in and know what a nurse is, what a doctor is, what a physio is, because it's not fair for physician associates to be in this kind of limbo where they feel that they're not fully recognized, and I completely understand that.
Brilliant, thank you. If anybody's heard what we've spoken about today and has any questions, could they get in touch?
Yeah, absolutely. I'm quite active on social media. A lot of my content is dermatology focused, but you can find me on most social channels. So Instagram, TikTok, YouTube even. Instagram's probably the best way. I do check that on a daily basis. Then if you kind of message me through that or email me through it, that'll be fine as well.
Perfect. And I'll leave the links to your social media channels in the show notes below so people can find them on their episode details. Thanks so much for joining me.
It's a pleasure. Thanks, James, for having me.
And thanks to you for listening as well. I hope you found that a really useful talk. I'll also link to Sina's publication in the show notes so that you can find it there and have a read through. If you'd like to, you can follow the PA Podcast on social media. We're at PA Podcast UK. I hope you'll join me again for the next episode.
Thanks for listening to the Physician Associate Podcast.